Thank you for joining iMeet.
Welcome everyone to the AABIP
This
webinar
meeting is
series.
now being recorded.
And before we get started, my name is David Shaw from Harbor UCLA Medical Center, and on behalf of myself, as well as my co-organizer, Russ Miller, from the Naval Medical Center in San Diego, I want to welcome everyone this afternoon or this evening to the American Association of Bronchology and Interventional Pulmonology's webinar series. Before we start, by way of a few introductions for everyone, I wanted to make sure that everyone in the audience knows that this webinar will be recorded. As a result, we request that you mute your telephones if possible, unless you're speaking, to minimize the background noise. There is a chat feature, and you'll notice at the bottom left-hand screen, for those of you who have logged in online, there is a chat feature which will allow you to type questions or ask questions of our speaker, and he can respond to you that way. Also on the bottom left-hand side of the screen, there is an icon that looks like a projector, and that will allow you to toggle the screen projection that we have of the images of our slides back and forth. As we mentioned, this webinar will be available for future viewing on the AABIP website, and we will have the website displayed for you in a second. The AABIP does not endorse any specific technologies or products, and the contents of this presentation represent the opinions of the speaker. For those of you who are unfamiliar with the AABIP, the American Association of Bronchology is the leader in helping patients breathe easier and live longer through minimally invasive diagnostic and therapeutic interventions. We have a number of different education and training programs, including involvement in IP fellowship training programs, IP board certification, but also our members get subscriptions to the Journal of Bronchology and Interventional Pulmonology, access to educational content such as this type of webinar series, which is held on a monthly basis, as well as other educational content. We have regional and group chapters, a biannual scientific symposium, and also annual research grant awards, amongst other membership benefits. You can find out more about the AABIP at our website, which is www.aabronchology.org, or you can follow us on Facebook, Twitter, or LinkedIn. So at this point, I would like to turn the stage over to Dr. John Mullon. He is the Interventional Program Director at Mayo Clinic and also has a prior experience as being a core program director for internal medicine. Before I turn that over, let me just mute the room one last time.
All guests have been muted.
And the other benefit that we have of having Dr. Mullon's expertise as our speaker today is that there has been a lot of changes with regards to the accreditation process and standardization processes for interventional pulmonary fellowship training. And John has been leading the way with regards to this process, and you may have seen that he is the lead author for the accreditation document that recently was published in CHEST. So at this point, I'm going to turn it over to Dr. John Mullon. Thank you very much today for joining us.
Thanks, David and Russ, for inviting me for this. I think that this is really a very timely discussion. I was looking at the attendees, and it looks like the vast majority of them are probably potential applicants for interventional pulmonary either this year or in the near future, and so hopefully this will be of some use for them as they go forward. Hang on, there we go. My disclosure: I have nothing from a financial standpoint to discuss. No medications will be discussed, and as indicated in the prior slides, any thing that's presented here will be my opinion. I'll try and as I point out things about the way I address applicants, I'll try and make that very clear that this is just my opinion and my way of doing things. Some other program directors may respond the same way to the things I say, and others may not. So here's the agenda. Now, I understand that the vast majority of you are probably trainees in pulmonary and critical care and maybe have a little bit of exposure experience interventional pulmonology. So I want to start by, particularly for those that are kind of just considering IP as opposed to those that are sold on the idea of IP, talk a little bit about the history of IP in general, and then give a little bit of a glimpse into where IP stands right now and where I see in the near future things are going. And right now, IP is in a very nice spot. Our programs are expanding very quickly. The applicant slots are expanding. We're gaining much more legitimacy within medical circles. You know, it's no longer when you go to a meeting and talk about IP, people look at you like they don't know what you're talking about. People know what IP is. It's really gaining a lot of traction within probably the last 10 years, possibly sparked by EBIS itself. But I think that it's really moving forward very quickly, and it's a great time to get on board with this field if you're a procedurally oriented internist within the field of pulmonary and critical care. And then at the end, we'll talk about the actual application process. I'll give you some pointers, and then we'll have some time for questions at the end. So there's a number of chat rooms out there, and some may have come across this, the Student Doctor Network. I don't know if any of you come across this. It was actually pointed out to me a couple of years ago, and they have a folder in there for interventional pulmonology. It started in March of 2012, and about 3 days after it opened up, this post came up, which actually has engendered quite a bit of discussion because there's 275 responses to this, and the comment was, "The hell, interventional pulmonology is a thing now? Everyone wants to be a surgeon, but doesn't want to put in the work needed to do it." And I think that very well illustrates a misunderstanding even back in 2012 and today, as a matter of fact, as to what exactly interventional pulmonary is. I think we're seeing less of that misunderstanding, but I do want to point out, that this has been around for a long time. This isn't a brand new field of medicine. Parts of interventional pulmonology existed all the way back to Hippocrates' time. So I wanted to start by just going a little bit through the history of interventional pulmonary. I won't spend a whole lot of time on this, but I just want to use this as a point to illustrate that this isn't just Johnny on the spot. This didn't just hit the street. This has been going on for a long time. In the last 10 years, we're starting to bring it now into a very cogent specialty, a subspecialty of medicine. But the crux of what's gone into interventional pulmonology and non-invasive therapies really dates back centuries. And that, in fact, back to Hippocrates' time. He was the first one to kind of endorse placement of a metal tube in the larynx of a suffocating patient, otherwise, percutaneous or surgical tracheostomy. This was back in 400 BC. He didn't do it. He just said, maybe it's not a bad idea. Patient's going to die anyway. Go ahead and put a tube in. Well, then, history happened, a lot of nothing for the next several hundred years, that is. Christianity was born, Rome fell, went into the Dark Ages, Islam was born. And it wasn't until, 1,400 years later that it was actually tested. So Avicenna Baccara, who was a Persian physician, very well known at the time, and actually considered the second Hippocrates, he didn't actually place a tracheostomy, but he wrote a book. And in the book, he described how to do it. And actually, it's very similar to the way it's done today. But then we, had some more history happening, Black Death, and it wasn't for another 500 years that it was actually tried. So Antonio Musa Brassavola, who's an Italian physician, not a surgeon, placed the first tracheostomy in a patient that had a peritonsillar abscess. Evidently, the patient did very well. He wrote it up, and this was the first IP case report back in 1546. But the word didn't get all the way around because a couple hundred years later, George Washington died because he needed a tracheostomy. Now, there's those who would say that he died because we took out 5.4 liters of blood bleeding him, but I think the tracheostomy might have helped as well. And we're in the 19th century, 1847, the AMA was founded. Some of these are just to kind of give you context. In 1845, Manuel Garcia was the first one to systematically describe what goes on at the level of the vocal cords. And he actually wasn't a physician. He was a vocal teacher, Spanish, but lived in London at the time. And he used a mirror on the end of a bended wire using ambient light through a window to be able to look at his vocal cords. And he actually went on to describe very effectively what happens when people phonate. Now, this is actually the birth of laryngoscopy. We didn't actually have any method of getting further down beyond the level of the mouth and the larynx, though, up until von Milkowitz and Leiter came onto the scene. This is, 30 years odd later. Von Michelwitz, was a Czech physician, And Leiter actually he made musical instruments. He wasn't a physician at all. But what Leiter contributed was the ability to create a light source. He had a coil that was hooked up to a heating source, and with that in place, encased in a glass tube, could be put down a steel tube all the way down into the stomach, and then you could see. So now the tube in the black hole actually had a light source. That was actually a very critical point, but you still couldn't use it in the airway because patients would gag and choke. Well, that was fixed by Freud, Kohler, and Jelinek. Now, these were all Austrian physicians. You may know Sigmund Freud. He was actually a psychiatrist, neurologist. Jelinek was an ophthalmologist. Kohler was an otolaryngologist. And they developed cocaine or found that it could be used as a local anesthetic. And now you could actually get into the airway and take a look around. And that was actually done the first time by Kirstein. He was a German physician. And he went as far as just into the proximal portion of the trachea using a laryngoscope, and he actually developed the suspension laryngoscope. Part of what made him famous. But we didn't really get any further on down until Gustav Killian and Chevalier Jackson came onto the scene a few years later. Killian in particular became probably the father of bronchoscopy, as he went all the way down into the right mainstem and pulled a pork bone out of a patient all the way back in 1898. Chevalier Jackson actually made a kind of a cottage industry of that. He pulled out 2,350 items from patients over the course of his 70-year career. And after you go to the Mutter Hospital or Museum in Philadelphia, you can actually see all the things that he pulled out, amongst other rather interesting things. 1905, the American Sanatorium Association was founded. That ultimately became the American Thoracic Society. In 1910, Jacobius took basically the instruments that Killian had developed, and rather than going through the mouth, went in through the chest, did the first thoracoscopy. And again, he was an internist. He was not a surgeon. It wasn't until 1918 that the American Association of Thoracic Surgery was founded. And then 1935, the American College of Chest Physicians founded. 1963, using rigid instruments, Howard Anderson did the first transbronchial lung biopsies. 1966, Shikedo Akita developed a flexible bronchoscope. WABIP, the World Association of Bronchology, founded in 1978 by Akita. At the same time, Professor Wang out at Hopkins developed the procedure of transbronchial aspirate. 1992, AABIP founded. 2003, curvilinear or linear EBUS was introduced, and this has had a huge impact on the advancement of interventional pulmonary. And then in 2011, the AIPPD, that's the Association of Interventional Pulmonary Program Directors, was founded. So key episodes just really within the last 120 years would be, the first bronchoscopy done by Gustav Killian, the first tracheoscopy done by Kirstein, first thoracoscopy by Jacobius, flexible bronchoscope Akita, and probably EBUS from a procedural perspective, things that have really moved the practice along. And so I would say right now, IP, it is a thing. We've been thinking about it all the way back to 2,500 years ago and then writing about it 1,000 years ago, but it really has taken off in the last 120 years with lights, optics, and sedations being key to being able to maneuver and do things within the airways predominantly. But we've gained a lot of additional legitimacy within the last 10 years. We'll talk a little bit more about this, but we've got a board exam. There's an IP fellowship accreditation process that is now going through. Most of the fellowship positions are matched through the National Residency Matching Program, and the JOBIP, the Journal of Bronchology and Interventional Pulmonology, is now indexed. So the work that we do and publish is now readily available and viewable by the general medical population. So these are all things that are moving the practice forward. And I would say, it is something now. It's actually kind of really on the crux of exploding into a very viable, independent procedural practice in and of itself. So question comes, I presume everybody here is interested in possibly getting on board with that. So what are you getting yourself into? Where is IP now, and where is it going? Well, so IP is riding the coattails a little bit of minimally invasive surgery, which of late has become quite the popular thing, not just amongst patients, but amongst medical economists as well. So this is a very important study published in JAMA back in 2013. Huge study. 320,000 procedures done through the VA system. and they compared standard surgical procedures versus minimally invasive. What they found is that of the 6 procedures they looked at, none of which were IP, but of the 6 procedures they looked at, 3 of them had a substantial cost savings when you look just at the dollars and cents in the healthcare plan spending. But if you looked at days absent because of the lessened trauma associated with the minimally invasive procedures, 5 of the 6 had a substantial improvement in days, working days lost. And when they actually rounded up the dollars and cents using 2009, which is where the data came from, they found that using minimally invasive techniques resulted in an $8.9 billion savings in direct healthcare costs. And this is amazing. 53,000 person years in workplace absenteeism. When you rolled that all up, it was $14 billion in savings in 1 year. Now, this based on 2016 national budget. If you look at our budget from last year, I'm not sure that the budget this year is even finalized yet, but the 2016 budget, that $14 billion is the entire federal budget for the Department of Agriculture, just to keep things in context. Half the federal budget for all of medical research, federally funded medical research, and a quarter of the federal budget for Medicare. And it would pay for the wall if Donald Trump could get his hands on that $14 billion. So this is a lot of money. And this is why medical economists and patients and insurance companies and so forth are pushing for this. Really, we're starting to see a huge movement forward in terms of minimally invasive approaches. Now, none of that study included anything from an IP perspective, but there is IP data out there that substantiates what we're seeing in those other larger studies. So if you look just at endobronchial ultrasound, you'll find that EBUS and EUS actually have a little better sensitivity than the gold standard, which would have been median stenoscopy. However, if you look at just physician payment, Medicare payment for EBUS TBNA, if you were to sample 3 nodes, physician service fee is going to be $267 versus $533 for perhaps a less sensitive procedure. And that's not even counting the OR time, the hospital time, the recovery time, the anesthesia time, and so forth, which would be lessened arguably with EBUS TBNA relative to median stenoscopy. Likewise, some of these procedures, the physician's portion of the reimbursement may be the same. If you look at medical thoracoscopy or fluoroscopy, it bills the same physician fee as a VATS pleural biopsy, $479. But the sensitivity of thoracoscopic medical thoracoscopy is actually excellent, 96%. And as has been demonstrated, you can actually do this on an outpatient basis. Patient comes in, you give them a little bit of sedation. They do not require single lung ventilation. They do not require multi-port access. It's single port access. They leave the same day, go home, do fine. And so the cost savings there is in all of the facility fees and ancillary support that would go into a procedure that would be done in the operating room with VATS relative to one that would be done with just in an outpatient setting medical thoracoscopy. Folks at Hopkins have also looked at this, and again, another procedure. This is percutaneous tracheostomy, and they compared about 100 patients, compared the surgical approach versus the IP service, and found there was no difference in complications, but an estimated $1.3 million savings per year for that single institution, favoring the interventional pulmonary service as the manager of the percutaneous tracheostomy. So all of this stuff, is all in vast support of what we're doing from an interventional pulmonary perspective. But I really don't think that anybody would argue that those procedures and techniques are well taught within a general pulmonary and critical care fellowship. Not that they don't do an excellent job; it's just not generally the focus. And that was actually substantiated in a study here that Nick Pastis from the Medical University of South Carolina published back in 2005. So this is, about the time that EBUS is coming out. And programs, 120 some odd programs responded to this. 76% response rate to a survey is excellent response rate. And they found that general pulmonary programs do a pretty good job training you in flexible bronchoscopy. 96% of the programs were able to achieve competency numbers that were established by the ACCP. Not as good as TBNA, 70%, and not real good in tube thoracoscopy, particularly when you consider that some programs had none, did perform none. But when it came to more complex procedures, and this is the stuff that validates an entire year of extra training, things like electrocautery, airway stents, medical thoracoscopy, laser therapy, rigid bronchoscopy, cryotherapy, photodynamic therapy, percutaneous tracheostomy, those things, very little exposure, with many programs offering no exposure. So substantiates that, if we're going to be doing this as pulmonologists, you really need to have an additional year of dedicated training. And that actually carries over into the practicing physicians as well. Now, this is an older study from 1995, but it was a great study. They surveyed 1,000 members of the American College of Physicians, and they had a great response rate, 736 responders. What they found amongst practicing physicians at the time, practicing pulmonologists, greater than 50% of pulmonologists felt they had inadequate training in advanced diagnostic techniques, such as TBNA, let alone EBIS or laser or so forth. Greater than 70% practicing bronchoscopists performed less than 100 bronchoscopies per year. And most interesting was that where advanced skills were practiced, so this is the laser and stents and so forth, greater than 80% indicate those skills were learned in a postgraduate course. This is a several hour to maybe day or two course, rather than a formal fellowship. Not particularly surprising, though, when you consider the time frame. This is back in 1995. And if you look at the number of IP programs that were available before 2005, there were very few. In fact, there were only 5. There was Henry Ford up here in Detroit, Leahy Clinic and Beth Israel up in the Boston area, University of Pennsylvania, and Hopkins. Those were the only programs that were out there in 2005. Well, but then EBIS starts to catch on. EBIS gains a little bit of momentum. People say, hey, EBIS is a pretty nice thing. People know that they need more training because it's shown in the survey of the pulmonary critical care fellowship programs. They weren't training EBIS at the time. So between 2005 and 2010, we had almost a tripling in the number of interventional pulmonary fellowship programs. And I will mention one thing here. There is one program that I'm not showing here, and that's down here. Medical University of South Carolina, which actually has an outstanding program and a great track record of producing interventional pulmonologists, but it's a different kind of program. They select from within their pulmonary critical care fellowship, and in their third year of fellowship, the ones that are selected then do a year of interventional pulmonary. So it's not a dedicated year, so I haven't included them in this slide here, but I just want to point out I'm not trying to overlook them. They actually do great work. Now, if you look at just the last 7 years, since 2010, we've gone up by an additional 20 programs, 5 of those within the last year. So we've gone from 5 up to 34 programs in the span. So we've gone up by 5 times, almost 6 times growth in the span of 12 years. So this is a huge explosion in opportunities to train in interventional pulmonology, and it just substantiates that there's interest out there in the community in what the services we provide, and there's interest in training the next generation of interventional pulmonologists, and the hope that we're going to continue to see this field grow. So here are the programs that are out there right now. Now this is based on what's up to date currently right now. I will say that there's one program that's not listed here, and that is the Medical College of Wisconsin does have a training program that will not be accepting a fellow next year. Ali Musani will be moving to Colorado, and my understanding the University of Colorado will be opening a program next year. So these are the listed programs currently. You can add to that the University of Colorado once it opens sometime this summer, I believe. But they span from coast to coast. You've got Massachusetts, Virginia, UCLA, UCSF way on the West Coast. You've got the Southern Pacific Atlantic states, Duke, Emory. You got the Great Lakes area, Henry Ford. You got the cold area, Mayo Clinic, New York, Memorial Sloan Kettering, NYU, and so forth. They kind of span the entire country. Lots of geographic exposure. We've got the University of Utah and Colorado going to be kind of covering the mid outer west here shortly. So lots of opportunities. Two programs in Canada, also excellent programs. Calgary, this is Elaine Tremblay's program, and then this is one of the older programs actually here from up in Montreal. So lots of opportunities to train, and we'll go over that in more detail. So why is this? This is a great time for those of you that are thinking about applying. This is a great time to apply. If you look at the data of programs that existed and the slots that were available over the last 5 years using the national match data, you'll see that we had 15 programs back in 2013. We now have 28 that go through the match. With that, we've gone from 18 training positions up to 32. But if you look at over the last several years, the number of applicants has been stagnant. It's been very flat, 37, 37, 37, 36, 37. And with that, you're seeing that the number of unmatched trainees is going down. not surprisingly. The programs themselves also are, IP in general is becoming a little less competitive. It's still a very competitive field, and I'll show you that slide in a second. But it's no longer almost impossible to get into. So back here in 2013, it was less than a coin toss that you were going to get a slot if you applied. There were 2.1 applicants per slot. We're now down to 1.2 applicants per slot and a 73% placement rate. So that's an excellent information for any of those that are thinking about applying. You got a great chance of landing yourself a slot now just because of the number of slots, the variety of slots that we just didn't have before. And we're still very competitive though. Pulmonary and critical care is about as competitive as interventional pulmonary, and we're still more competitive by a long shot than interventional radiology, which would be one of our kind of, I would say, correlate programs, correlate practices. And if you look at the placement rate across the vast majority of training programs out there, specialties out there, you see that interventional pulmonary is still very competitive. So we're the fourth most competitive matched program behind rheumatology, gastroenterology, and pulmonary critical care. And this is using 2017 data. Back in 2013, we were the number one, most competitive. We're as competitive for placement as thoracic surgery, more competitive than hem-onc, cardiology, vascular surgery, interventional radiology. So still a very competitive specialty to go into, but I think that the tension in that respect is letting up. Now the question comes up, okay, so I apply to interventional pulmonary, get a slot, good for me, but then what? I can't get a job. Are the jobs keeping up with the training slots? I don't have all the data on that. No one does. But what data there is this nice study that came, Hans Lee from Hopkins, but also Lonnie from Hopkins, Adnan from Beth Israel, and Shaheen from Ohio State, and David from Hopkins, put this nice survey together looking at the trainees graduating between 2012 and 2004, sent them out a survey, got 53 responses, and found that of those that had graduated between 2012 and 2004, 87, almost 9 out of 10, took interventional pulmonary positions upon graduation, 85% of those in academic positions. Only 9% took non-IP slots, and only 1 didn't have a position at the time of completing training, although my understanding is that that was corrected within a couple of months of graduating. But one of the most interesting things to me was that of those who had a slot, better than half were hired to start new IP practices, and that has continued to be the case. We're seeing new practices pop up not just in academic centers. This used to be very much isolated academic centers. We're now seeing jobs become available certainly in cancer centers, but also in health systems, hospital systems, and so forth. So, having access to minimally invasive, skilled interventional, fellowship-trained interventional pulmonologists is very much becoming a thing that institutions and hospital systems want to have. They want to have that in their armamentarium. So what about your life as an interventional pulmonologist? Okay, you're going to spend a year in interventional pulmonary. Am I going to make money to pay back all the bazillions of dollars of debt I've got? Am I going to be working my butt off? Am I going to hate it? Well, so the AABIP did a survey of their 800-plus members this last year and asked them, what do you do and how much do you make and how do you like your life? Now, I'm not going to present all of that data, but I'm going to show a few of the pertinent slides to kind of make the case that it's a very nice practice. It's a very nice profession. So first of all, I'll point out that still the vast majority of the positions out there are in academic centers, about 75%. But interestingly, we're starting to see this private practice sector increase. So that's now about a quarter. If you stick in here the managed care and VA only without an academic component, about a quarter of the jobs out there now are private practice jobs or non-academic center jobs. We didn't used to see that before, so that's an entire new area of growth within the opportunity for jobs and availability going forward that may appeal to many of the applicants. What about salary? Well, so there's concern, right? Okay, so there's most of these are academic jobs. Academic physicians make less than their comparative colleagues in the private sector. And that may or may not be actually true. So when you look at the salaries that are reported, and those who've reported in the survey, if you're an academic job, the mean salary was $282,000, which actually, if you compare it to general pulmonologists across the country, academic and private practice, $281,000 was, at least, of course, the Medscapes study was the average salary. So it's pretty comparable to what you'd be making as a general pulmonologist. If you happen to be in private practice, you're making a whole heck of a lot more than I'm making, $434,000. So that's more than either pulmonologist or intensivist is making, but not too far off from what a full professor in an academic center would be making. So in terms, I'm going to make the case that in terms of salary, there's probably pay parity between interventional pulmonologists and general pulmonologists. You can disagree with that, but that's what I take from this data. What about lifestyle and whether people would choose this as their field going forward? This, I think, is probably the most compelling data. So the question was, if you have the opportunity to choose your medical specialty again, would you choose interventional pulmonology? 2/3 said absolutely yes. About 30% were kind of, I don't know, kind of some days it's great, some days it's not so great. Only 4% said no. Now, if I think you put that question to any other practice in medicine, you're going to find numbers that are far less than this. I just know, talking to my colleagues that just do straight pulmonary, I don't think that 2/3 of them would be saying, yeah, I definitely would do this again. They might be more in the maybe category. My point here is that people that do interventional pulmonology, they've selected this, they've committed time to it, an additional year of training, and they enjoy what they do. There's a future too. So it's not just rigid bronchoscopy and thoracoscopy anymore. We're on the threshold, I believe, of being able to add an additional therapeutic option for our patients. Everybody sees these multiple GGOs that come in with the screening CT scans and so forth, and many of these are going to evolve into pre-malignant and malignant processes of low grade. And we're always struggling in our tumor boards to what are we going to do about these? We're going to cut them out, but we want to remove as little tissue as possible. Ablation is becoming much more a thing for us, and I suspect that's the case in most centers. Most of it's done by interventional radiology, percutaneously. But now, with navigation and the ability to localize and reliably ablate, and devices are being built that will allow that, I think that this is going to fall into the hands of the interventional pulmonologist to identify, localize, diagnose, and ablate these GGOs. This is just an example of, so we've got a study going on here where we're using electromagnetic navigation to get within the 10-yard line of the lesion, and then for the last 10 yards we're using cone beam CT scan to make sure that we are directly on target. And the idea here is that we're getting our skills now so that we can ultimately, when a catheter exists, we can put it right in the center of that thing and ablate it. And ablation works. So here's just some data, or just some pictures, just one case, isn't really data, of an ablation that was done with cryoprobe by one of our interventional radiologists, and you can see that certainly this worked, and actually this is at 6 months, but follow-up, I understand, on this patient was favorable at 3 years. There are a number of devices that are being developed. Microwave is getting a foothold. Cryo is getting a foothold. There's some places still dabbling with radiofrequency ablation. The point is that ablative devices are being developed for deployment through the bronchoscope. This should become a large part of our practice and make us ever more valuable and viable as a field going forward. So I think that there's a great future. I think things are great now in interventional pulmonary, but I think there's a great future going forward. So hopefully I've convinced you all that you didn't make a bad choice about thinking about going into IP. Now let's talk a little about how you're going to get there. So how to apply. Well, first, there's a few things you're going to have to supply to all programs. So minimum of 3 letters of recommendation. First of all, you have to be coming out of an accredited pulmonary and critical care fellowship program to be eligible to apply to start with. And then you're going to need to supply 6 things. 3 letters of recommendation, 1 which will be coming from a program director. Now, this is my opinion. Get letters from faculty that know you well. It doesn't matter if the letter comes from the chair of medicine or the world's most famous interventional pulmonologist. If they do not know you, they will not be able to write a compelling letter. It's better to have a letter from an assistant professor that knows your skills than somebody who doesn't know your skills. Additionally, if you can get some comments about procedural skill, that is extremely helpful. It's a procedural specialty. Not everybody has a lot of eye-hand coordination and psychomotor skill. We were looking for that. It's a 1-year fellowship. If you're all thumbs, it's going to be tough to teach you, and it's not going to be enjoyable for you or for your faculty. So if you can get somebody that knows you and can comment on your procedural skill, that's very helpful. Now, I would caution about the use of external rotations. I understand that in some training programs you don't have access to an interventional pulmonologist, and so you avail yourself of opportunities at Mayo Clinic or Hopkins or wherever these places that allow you to do an external rotation. You go there for a week or two and then ask for a letter of recommendation. I would say that those letters are most useful if you actually develop a relationship with the person that's writing the letter, albeit for a brief period of time, and that they can comment arguably about your procedural skill and maybe even maintain a relationship. So those are where those are most useful. What I see many times, these letters come in from these places where you've done an external rotation, and many trainees and applicants have gone to the same place, and the letters come in and they're identical with just the name change. That's not helpful. 3 strong letters from people that know you well, that carries the day. Personal statement, letter of intent. Everybody's going to fill one of these out. I've got your CV. Everyone's got your CV. I don't need to know what you've done. I can find that. What I want to know is what you intend to do. Are you looking for an academic practice, a private practice? Are you interested in research? Are there specific things that you're trying to get out of that year? And I want to see if it meets with what we can make available to you, because it may be that maybe we're not the right place for you. So really, and I guess I'm not all that interested in why you went into medicine, your love of humanity, and that kind of stuff. I don't want to sound crass, but that was medical school application. This is IP. We know that you love humanity. What I want to know is where you're going to go next. You're going to send in a curriculum vitae. It should include your NRMP number. We can get it otherwise. It just makes it harder. USMLE scores, again, my opinion, I don't put a lot of weight on the USMLE score unless you happen to have failed 1 or 2 steps. That's usually a red flag. But if somebody scored, I don't know, 120, another score 180, whatever, that doesn't, I'm not stratifying you based on your USMLE scores. We know that you're all good. You've gotten this far. Your scores on your USMLE really don't carry that much weight as long as you pass the test. Word about the procedure log. I think everyone that receives the procedure logs from applicants would agree a 30-page spreadsheet with every procedure you've ever done is very painful. If you could, one, it has to be de-identified. And if you could summate your procedures, don't send me the 30 pages, but say I've done 110 EVIS, and I've done 20 percutaneous tracheostomies, and I've done 50 tunnel pleural catheters. That is useful, saves me time, and it actually, because I'm going to go through and count this stuff up anyway. So if you could send it to me summated, I think that's much more helpful than everybody sends in a picture. How to get it where it needs to go. All right, so you can either mail and email it to the programs, but most of you are going to avail yourselves of IPFAS. That's the Interventional Pulmonary Fellowship Application Services available through the AIPPD, through their website. I'm going to show you how to get there. Now, it's not free, but it does give you the opportunity to apply to multiple programs without having to do them individually. You just click the box and you pick the programs that you want. It's $100 for 8 programs and $10 additional for each program over 8. You can start putting in your applications around 30th of June 2017. So it's a very convenient thing. It's convenient for the program directors. It's convenient for the applicants. So I would recommend you at least look into that. And here's how you get there. Now, and I don't know if I did it. Maybe I should this in the next slide. Here's how you get there. So go to your Google buddy and type in AIPPD. And the first hit should come up as the Association of Interventional Pulmonary Program Directors. Click on that. Going to bring you to their home page, and their home page is a command bar across the top. And right square in the middle is applicants. You click on the applicants, and it's going to take you to the application process. Read all the legal stuff in here about how you do it, and then you click on this button right here. This is the actual go to the application button. Get you to this screen. Here's where you create your profile. You put in the information about yourself, your email. You create a password. Here's all the programs that are going to be listed out here. You can go ahead and pick the programs that you want, and then you're going to pay at the end. Very convenient. It's certainly convenient for all of the program directors, and I believe everyone I've spoken to finds this very convenient for the applicants as well. Now, I will make one comment, though. Not every program is listed on the IPFAS website. The University of Texas MD Anderson does not participate in IPFAS. That's not a negative thing about them. They have an internal application engine called Discover. Now, if you're interested in IP, you're interested in MD Anderson Cancer Center. They provide an absolutely fabulous experience for trainees, and so you should be looking hard at this place. Don't let this get in your way of applying to MD Anderson. It's a great program. But what you will have to do is get a hold of George Epen at MD Anderson, and he'll be able to direct you in how to get into their Discover, their internal application engine. All right, so you sent this awesome application, great letters, everybody loves you. Now we're going to get to the interview. So the interviews here are not that much different than interviews for everything else you've ever done in your entire life, but I am going to give you a couple of pointers, so a couple of tips. Tip 1, apply to the programs you actually would consider matching to. A couple of reasons for that. Many programs, mine included, we don't interview everybody. We have a limited number of interview slots. Some programs do interview everybody, but we don't. And so if you're coming to Mayo Clinic and really have very little interest in matching at the Mayo Clinic, you're really taking a spot from somebody else that might be good in the program, and the program might be good for them. So don't do that to your buddies. That's not the right thing to do. What are you going to do? How are you going to decide that? My usual feeling is if you got 8 places that you're going to apply to, you should probably, before you even go to the interview, you should probably already know how you're going to rank them. They might change a little bit, but that means that you have to have done research. So what are the tools you can tap into? Well, hey, speak to the prior graduates of that program. If you get a hold of the program director at the programs you're interested in, they'll probably give you the names of their prior graduates. Talk to them. And they're out of training now. They got nothing to lose. They're going to give you the real deal. They're going to tell you what the strengths, the weaknesses are, what they like, what they didn't like. That's going to be very, very helpful because they've lived your life that's about to happen. Look at the faculty within the program. See what the research is. Does it match your interests? If you're interested in confocal bronchoscopy and all we're doing is research in photodynamic therapy, maybe it doesn't match quite right. Does the patient population match your career aspirations? You want to work in a cancer center? You got Memorial Sloan Kettering and you got MD Anderson, both dedicated cancer centers. Both of those ought to be on your list. Both of them are going to carry a lot of weight. If you want to do transplant, you should be looking at places that do a lot of transplant. So does the patient population match your career aspirations? Geography. I hate to say this because I live in Minnesota, but we struggle with geography all the time, but it's a real deal. If you hate the bitter cold, maybe Mayo Clinic isn't the place to apply, or maybe Michigan, Wisconsin, Iowa, those places, main places not to apply. On the other hand, if you hate the heat, maybe Louisiana, Texas, Georgia, Florida, maybe those aren't places to apply. Geography does have bearing. It is only 1 year, but I understand that some people just can't find themselves shoveling snow in January, and so it does come into play. The other thing to keep in mind is, you got spouses or other things that lock you into a certain area. That's going to limit things, obviously. Cost of living, it's 1 year, but cost of living does have some bearing, so you may want to look at some of the programs that are in very expensive locations. And it's important to know about job placement after graduation. This is a place that has been successful in getting their graduates into a job. Tip number 2, read the IIP Fellowship Accreditation Standard. Okay, so this standard is published. It's on the AABIP website and the AIPPD website. It does not become fully effective until the matriculating class of 2019 to 2020, but it is a framework that says, look, 5 professional organizations have sat down and decided this is what an IIP Fellowship should provide to its trainees. Line by line, it's about a 30-page document, but know it because your program director is going to know it. You should be able to ask questions about it. Ask questions about procedural volumes, curriculum, facility, all those kinds of things. Ask them to the program director. That's going to be a way that you can stratify programs based on the resources that are available. And why does that matter? Because not all programs have the same procedural volumes or procedural types. This is a study. This is published in 2013, and it's probably still pretty accurate. Lonnie Yarmus talked to 20 of the programs that were out there and found quite a bit of variability in the number and types of procedures that were performed in different programs, to include programs that didn't do certain procedures. For example, 5 of the 20 programs, a quarter of them, don't do medical thoracoscopy. 4 of them don't do cryotherapy, and 6 of them in this series anyway don't do laser therapy. So these are things you need to know because all of these things are required procedures. So here are the mandatory procedures that programs are supposed to give you access to when you train, and numbers thereof. So rigid bronchoscopy, interbronchial stenting, thoracoscopy, navigation, ablative techniques, interbronchial ultrasound, image-guided thoracoscopy, tonal pleural catheters. Those are the mandatory procedures. But there's also optional procedures, percutaneous tracheostomy, PEG tubes, thermoplasty, those kinds of things. So these ones aren't required. Depending upon what your career goals are, they may be something you're interested in. You need to know this, know what the standards are, ask about it. I don't think there's any program director that's not going to give you that information. Tip number 3, know how you get paid. These are non-ACGME accredited programs, which means that you don't get Medicare dollars to supplement your pay and benefits. Some programs don't require you to do any additional work to earn your pay and benefits, and some do. So you should know about that because any additional work you're going to be doing outside of your fellowship program may, in fact, detract from your fellowship program. And additionally, if you're on a J-1 visa, you should know that you can't work either moonlighting or within your program to earn pay for your pay and benefits because you actually can't bill. So J1 visa holders, that's a special entity that makes it a little bit more challenging. But you should know how you're going to get paid, where the money's coming from. Last question. This one you've been through, so I'm not going to spend a lot of time on this. You guys have all been through interviews. But there are some don't ask questions. Mostly they pertain to the program staff. Program staff should not be asking you about the names of places you're applying, your ranking preferences, what other specialties you may be looking at, geographic location, or any of that kind of stuff. They shouldn't be asking that. Likewise, you should not be asking the programs where they intend to rank you in their rank order list. Why is this important? Because if it's found out there's an infraction either on the part of the program or you, there are sanctions that are applied, and either you or the program having sanctions applied could inhibit your ability to move on to the next level into that fellowship program. And so you want to make sure that you play by the rules. Okay, so we've been participating in the match now in IP since 2012, but not all programs do participate in the match. This is the list of programs that were in the match last year. The ones that are in this kind of Georgia clay red, those are the ones that participated. There were 7 programs that did not. Now, that doesn't mean they won't this year, but last year Chicago Chess, I don't think Chicago Chess has ever participated in the match. Not a strike against them, it's just they haven't. Penn State, UCLA, these are newer programs. Maryland, Minnesota, Utah, and Wake Forest did not participate in the match. That may change this year. I'm just letting you know that not all programs go through the match. There were 28 programs last year, but 32 positions because some programs have more than one position. In fact, Cooper, MD Anderson, and Beth Israel have more than one trainee at a time. That can be a good thing, and it can be a not a good thing. So that's something to explore when you talk to the program directors about that. As long as they have adequate exposure, resources, procedural volume, having more than one trainee can actually be a good thing because you can share a call and so forth. Alternatively, if it's a marginal in terms of procedural volume, faculty numbers, and faculty accessibility, having more than one fellow sometimes can be a detriment, something you'll have to talk to the program directors about. One piece of information I want to make everyone aware of because it's often forgotten. Any program director from a match participating institution, even if they don't participate in the match, can have no interviews and no offers from the time, these are for out-of-match positions, from the time that the rank lists have to be submitted to when the day of the match. That's a huge no-no, and that would result in sanctions. So here are the dates you need to know. Match is going to open on the 30th of August. That's when you can go and enroll in the match. Your rank order list is going to open on the 4th of October. So you can actually put your rank order list together until the first week in October, although you can enroll in the match. Rank order list closes. This is your last day on the 15th of November, and then between 15th of November and actual match day of the 6th of December, it's about 3 weeks. No funny business. No interviews, no accepting positions. Programs can't offer you positions. You shouldn't be pursuing positions at that time. It could result in you losing the ability to actually match that year. So you just need to know what the rules are, play by the rules. The match is a very fair organization, but they do have certain things they stand by. All right, we'll just wrap things up, and then we'll have time for some questions. So, look, interventional pulmonary, it is a thing now. It's really growing at a rapid pace. In fact, it is the fastest growing subspecialty of internal medicine right now, faster than any other. Never been a better time to apply for IP fellowship. You got board certification now. Fellowship accreditation is coming down the road. We're starting to standardize the experience. You currently have the most favorable applicant to position ratio ever. Within the field, it looks like there's pay parity between those who do the fellowship and those who don't, but the ones who do and like it have excellent job satisfaction. And this is a rapidly evolving practice, and I expect to see it continue to evolve very quickly. Industry is developing a lot of interest in what we can provide, and I think that this field is going to continue to explode. But be a smart consumer as you're going through the process. Research programs and faculty, know about the faculty, know what their research is, know what the program is strong in, know what you want to do. That's probably the biggest thing. Talk to current and recent fellows. Don't be afraid to email program directors. I think all of us are happy to talk to anybody who's interested in our program, and of course we're going to make it sound like it's the greatest program ever, but I think we're all pretty honest as well. Read the accreditation standard and judge programs accordingly. This is the only objective way you're going to be able to compare apples to apples, and I would really encourage you to take the time, read through it, know what the standards are, and guarantee the program directors are going to be striving to meet those standards, and so you should be able to have a very detailed conversation about that. Have a career plan and apply to programs that best help make that a reality. Right now that might seem difficult, but if you know that you want to go to a cancer center and when you graduate from IP fellowship, you're going to need to have a couple of programs. You're going to have to have cancer centers, MD Anderson and Memorial Sloan Kettering. They got to be on your rank order list. If you're looking at an academic career, you're going to be looking at programs that put people in academic positions. If you're looking at, let's say you have a particular interest in transplant, you want to go to a place that has a lot of transplant. And if you're interested in private practice, pretty much any program out there will prepare you for that. Pay attention to your timelines, know and follow the rules. And hey, everybody, good luck. It's a lot of fun going through the match process. It's fun when December comes. It's like opening a Christmas present. You find out where you're going. Everybody's happy. It's all peaches and cream. All right. Hey, I'm ready to answer any questions.
So while we wait for people to type in questions, I just wanted to thank everyone for joining us today and remind you that this is our website for the American Association of Bronchology and Interventional Pulmonology. And if you have an interest in IP or learning more about IP or joining the AABIP, this is where you can find us. So we have a question from Layla Sami. I apologize if I misspeak anybody's names. And the question is, are the Canadian programs that are part of the AABIP included in the NRMP as well?
No, so they're not. They have a separate selection process. The NRMP only pertains to programs within the United States.
Any other questions from the audience for Dr. Mullon? So we have another question from Jonathan Liu. He asks, can Canadians participate in the match for the United States positions for IP, and which programs take Canadians?
So the answer is yes. For you to be able to apply for an interventional pulmonary training program within the United States, you have to either be a graduate of a pulmonary critical care training program within the United States or a program within Canada through the Royal, I'm going to get this wrong, the Royal College of Physicians, I think it is in Canada, accredited programs. Those are acceptable. As far as I know, there's no program that would necessarily prejudice against a Canadian applicant. No one's mentioned that to me. We certainly wouldn't, and we're pretty close to Canada. Although I'll admit, I've never had a Canadian applicant. Maybe it's just
another question is, sorry, hold on, it's scrolling up on me. Are COMLEX scores accepted or only USMLE?
So I think you'd have to talk that over with the programs themselves. I don't have a problem accepting a COMLEX score. I don't think really any programs would. I kind of illustrated this. And I think most of the program directors would agree, I don't place a tremendous amount of weight on board scores unless you failed boards. If you pass them, I don't think that's a great discriminating point between what's going to be an excellent fellow and a not excellent fellow. It just doesn't seem to work out that way.
And another question is that if the opening day to submit is June 30th for your application, can your letter writers submit their letters prior to that date?
They can't submit them prior to, but they can submit them after.
And what research accomplishments do you expect from a second-year pulmonary critical care medicine fellow? Unfortunately, it scrolled up on me, but I'll start with that.
Okay. Well, so again, this will be program to program variability. We like to see that you've been academically productive during your fellowship. I don't really put a specific number on the number of publications. I would say that we do like to see that you've had abstracts, and that the abstracts have been more than just abstracts and posters at a meeting, but they've gone on to something that went into print. If it doesn't necessarily have to be interventional pulmonary, we understand that that's your career choice, but we also understand that not everybody has access to an interventional pulmonologist in which they can do research. So we just want to see that you have the ability to take a thought through the abstract phase and make it all the way into the publication phase. It doesn't even have to be in a top tier journal. We just want to see that you can do that. Now, and I will say that we've interviewed people that have 50 publications and PhDs and not ranked them. for various reasons, and we've had other people that we have ranked very highly that have no publication. So, it's a piece of information. And I know that other programs would disagree with this, that they place a tremendous amount of weight on number of publications. I would say that is not a primary factor. It is a factor we consider, but it's not the only factor.
And we have a couple of questions that are related. One asking about J1 visas, how much of a disadvantage, and then a second one similarly about H-1B visas. Is that a problem in the United States?
So I'll start with the H-1Bs because it's a little bit trickier, and there's fewer of them. There's not a lot of H-1B applicants out there. So the J-1 are education visas. So that's an individual that's coming to the United States to learn a skill and then either go to an unserved area, which many do, or to return to their home country. The H-1Bs is actually a work visa. So the issues with the H-1B is that it's a 3-year that can be extended to 6 years, not extended to 7 years unless you apply for a green card by your 5th year of your visa, and then your visa is extended until you have adjudication of your green card status. So if you were to be an H-1B visa holder and had applied for your green card, it would not be an issue. If, on the other hand, you are an H-1B holder and you have not applied, and now we know that you're in your 6th year of training and you're not going to get a 7th year because you haven't applied for your green card, that is an issue because you're, particularly under the current environment, I don't expect they're going to allow you to remain in the United States, and that certainly creates a problem. Again, I've got one training program slot, most of us do. If you don't fill it, we could have filled it with somebody else, and that's a lost interventional pulmonary practitioner. So the H-1B is only an issue if you have not applied for your green card. Now, I'm not going to suggest that I'm an expert in visas, but that's my take on it. Now, the J-1s, on the other hand, different programs will handle this differently. J-1s cannot bill independently. If the program is relying on the fellow to do their own billing to generate revenue, then it creates a problem because the J-1 visa holder will not be able to do that. If, on the other hand, the fellow is not expected to do any revenue-generating work and not do their own billing, then it should not be an issue. But again, different programs handle it differently. I wouldn't pay attention to J1 status personally because we don't expect the fellows to generate revenue here, but other programs may view that differently.
So on a similar light, there's another question as to whether or not there are any programs that have declared that they do not entertain J-1 visas, or is that something that they should discuss directly with those programs?
You'd have to discuss it with them. No one has made those overtures to me, and I've never asked the question to all the program directors. You would have to address that individually with the programs. I think that look, everybody that's a program director wants to train, the best fellows that come through, and I think we do the best we can to try and, independent of any kind of visa issues, try and get you through into training. So, but again, you'd have to bring that up with there's certain business and monetary constraints that are placed on different programs that may have an impact on that.
Okay, a couple of other questions before we run out of time. One is, can United States citizens apply for Canadian programs?
Yes.
Perfectly succinct answer. The next one was, are there any disadvantages, or how are applicants who have been in practice a little while, who are now looking to come back for an IP program, how are they viewed?
Well, again, this would be different programs view things differently. I've had a number of in fact, one of our fellows from I think the time before last was in practice, and we took him for training. So I don't, again, different programs may view that differently. I personally can't come up with why it would be a disadvantage to having a practicing physician come through training. I would want to know that their career goals married up with what we could offer them. But that would be the only thing. But again, that's very program and program director specific. So I don't know that I can answer that in a way that is 100% accurate across all programs.
Okay, well, thank you very much, Dr. Mullon. We're going to be running out of recording time here, but I do want to thank you for taking the time to put together this very comprehensive discussion of the field of IP, how it's growing, and then, of course, also how to apply and some of the considerations of applying for interventional pulmonary fellowship. Again, for those of you who have joined us, this webinar will be recorded and also available for future viewing on the AABIP website. So I hope that this was useful for you, and please contact us at the AABIP if we can help you any further with this. Thank you very much.